Good morning, and welcome to this week's episode of Ask Dr. Murphy. I hope everyone is doing well today. My name is Katie Berg. I'm a research study coordinator with the Havey Institute, and I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you today?
I'm doing quite well here back at Chicago.
Dr. Robert Murphy is the executive director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, infectious disease, or public health questions each week on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be addressing the latest headlines and U.S. COVID statistics through today, February 8th. We invite you to submit any questions down below via Facebook at NU Institute for Global Health or by email at globalhealthinstitute@northwestern.edu. Starting with U.S. COVID statistics for this week. Average new hospitalizations per day, 3,234. Last year, the same week, we saw 4,055. Average COVID deaths per day, 133. The same week last year, we saw 415. New 2023 vaccine uptake for adults is 21.8%, 41% among adults 65 plus, and 11.6% among children. Dr. Murphy, your reactions to those numbers?
The numbers are still high. We're in the peak season for respiratory infections, so they're all still out there. There's a little wobbling around, like it's not like increasing dramatically, but still 131 deaths per day. You're talking tens of thousands per year. I mean, this is still a big problem, and people are not taking it as seriously as they should. It's a potentially lethal disease, particularly if you're in a high risk group, predominantly elderly, but anybody with any underlying cancer or anything like that, any immunocompromising condition, really needs to be concerned.
Absolutely. And speaking of that concern, while the numbers are lower, and thankfully we're seeing a lower death rate than we did last year this time, the CDC did release their variant of concern report for this week. And very surprisingly, one variant is now very, very dominant in the US. Can you break that down for us?
Yeah, this is the JN.1. We've mentioned this before. So this appeared in August of 2023. And now it's 93.1% of all the isolates in the United States. It's just completely taken over. So that just shows you how this thing evolves over time, as long as, and this is going to continue. And hopefully it's going to be, relatively mild Omicron type variants out there, which this is one. So it's relatively mild, but there's a lot of it. And the wastewater sampling that's being done around the United States and the world is high. There's a lot of it. The good news is the vaccines still work. If you're up to date with your vaccine, it's 50% effective of preventing symptomatic disease. So that's good. That's great. This is like kind of in the same ballpark as the flu vaccine. They've looked at this variant versus the other variants. The beta variant and the Delta variant were much worse. They were really 4 times more severe. So we're lucky we haven't, regressed into something like that. But kind of anything is possible. So we've got to keep up with watching these variants and see what the next one will happen. And don't forget, this is a preventable disease. Nothing's 100%, but I mean, 50% from severe disease. It has a potential treatment as well, which we're going to talk about next.
Mm-hmm. So speaking of that treatment, there was a very big announcement from the FDA regarding the ending of emergency use for the well-known COVID antiviral Paxlovid. Can you tell us about the date when we could expect to see that end and what this really means?
So Paxlovid was approved under the emergency use authorization mechanism because it was an emergency. Well, the emergency isn't over, and it's has transitioned to regular approval, and that's going to all happen on March 8th. So what does that mean? Well, that means it's going to be sold just like any other drug. Until the end of 2024, through a variety of federal programs, people on Medicare, Medicaid, and the uninsured, even though they've got to jump through some hoops, can get it for free. This is a drug that is now being marketed at $1,300 per treatment course. It's a 5-day course of 3 tablets twice a day for the 5 days. This is really, really an outrageously high price. And that has a big impact on uptake because people hear $1,300, I'll just get through this or whatever. This drug actually has a very high success rate in preventing hospitalization and death. I mean, it's been proved in multiple studies. I mean, over 50%, and even in some of the highest risk groups. So it works great. But a lot of doctors are put off by this. There are a lot of drug interactions, people on multiple drugs, they have to be careful. But remember, it's only 5 days, and you can modify or hold the other drug or take a lower dose. It's up to your doctor and your pharmacist and you how you're going to do that. You only got to do that for 5 days. But it's a combination of the medical doctors being a little bit reluctant. Most of the calls I get for Paxlovid, people that want it say, do I really need it? And some 68-year-old person's calling me up. I said, yeah, you really need it, or you've got some underlying disease. The doctor said, oh, my doctor said I didn't need it. This is wrong. The pharmacists are reluctant to even stock it because it's so expensive to stock, and they've got to keep this inventory of it. And people are just put off by the whole price. And those in the middle class and the working class and anybody with regular insurance, 100% payment is not guaranteed. And you may have to pay a copay up to 20%. And of course, there's different hurdles you can go through to get that waive. But I mean, every time you put in these obstacles, people will take it. And it's very underutilized. I think it's fewer than 20% of people that should take it are taking it. So there's a great benefit to taking this drug if you get COVID and you're in a high-risk group. And you don't really have too many other options. There's one other drug, molnupiravir, made by Merck. But that drug has some other issues. I'm not really going to go into it, but it's not really apples and apples. It's apples and oranges, and it's a little bit different drug, and it's not as favorable. Let's put it that way. So anyhow, it's exactly what's happening here is exactly what unfortunately should be avoided. Because it's hurting people that could really benefit from it. Some good news is that there are several other drugs in development, very close to being approved. One is approved in China already. That looks like it's just as good, but they haven't done any of the studies outside of China, so I don't know how that's going to get approved. But there's other ones actually being developed globally that at least can get some competition going in the market and get the prices down and maybe get something that's better tolerated, maybe once a day, easier to take, fewer drug-drug interactions or whatever, or at least a less expensive alternative here. So I think the future will be good, but right now in the season, you don't have any choice. You just have Paxlovid. And, if you are at risk, if I get COVID again, I'm taking it. And I'm totally up to date with my vaccines. That doesn't make any difference. This drug works whether you're vaccinated or you're unvaccinated.
Mm-hmm. And worth noting that while molnupiravir is less favorable, it still does retail at a very, very high price, just under $1,000. So as you mentioned, that competition hopefully coming in soon at a much lower price, more accessible to people who need it.
Yeah, it's cheaper, and but it's got some other issues as well. But it's better than not taking anything.
Mm-hmm. Switching gears a little bit, there is new news, a study out of the New England Journal of Medicine regarding a single-dose dengue vaccine and its efficacy. We've been talking a lot about dengue and other mosquito-borne diseases. So can you break down those findings for us?
So dengue is increasing like crazy. The mortality rate is very low, thank God, but there's still thousands of people die from dengue every year, and you can get really sick with dengue. And you can get dengue multiple times as well. So anywhere in the Caribbean, the tropics, Mexico, Latin America, all over the Americas in the tropical areas, even in the United States, we reported several weeks ago that there was de novo cases in California. So it's as the planet warms up, the mosquito that transmit this, moves up too. Moves as the weather is favorable for those mosquitoes, even into the United States. So this is a great achievement, and if you're in an area where there's a lot of dengue, or you're going to an area for a while that is a dengue area, like Brazil, where the study was done, you can consider taking this once it gets approved. So I imagine it's going to be approved very, very shortly, based on this very large study, 16,000 people, and reported in the New England Journal of Medicine, which is our top journal in the United States.
Absolutely. And in general, there was some breakdown between different groups, different adolescent groups that are at risk. But I believe in general, there was about an 80% efficacy of that single dose vaccine.
Right. And for up to 2 years, maybe
Very
longer.
important.
They followed them for 2 years. One
Now,
dose.
yes, one dose, which is very important
Mhm.
for, getting those vaccines around. But switching gears back to COVID, this is a topic that we've talked about a little bit here and there on the series, but there has been more information, more studies coming out, adding to the breadth of evidence and literature on these topics. This study specifically is on sperm quality in men following COVID-19 infection. Can you please, break down what the study found and what they were
Yeah, so
reporting?
these studies are a little challenging to do, but they're doable. And they studied 85 men who had samples before they got COVID, then COVID, and after. And they found that there's a big change in the sperm count. Some studies have shown in the function of the sperm and everything after infection. It generally reverses over time. However, the really interesting thing here is that these were people with mild COVID. So they weren't super sick or anything. We know when people are really sick, the sperm function can be, can be affected. So again, more data that even having mild COVID, if you're a man, not good for you, at least in the short run after you're infected.
Mhm. And an area that will keep looking for larger studies or comprehensive reviews of all of the studies that have been published to try to get the bigger picture image on what's going on there.
Right.
But today, our final story, syphilis is soaring in the US and it hasn't seen numbers this high since the 1950s. Can you break down those numbers and why this is so important?
Yeah, I mean, other sexually transmitted infections have either kind of peaked or have been dropping a little bit. Syphilis has just skyrocketed. Now, part of the issue is in prevention, and people take to prevent HIV, which is of course very serious. People can take what they call PrEP, pre-exposure prophylaxis. They can do a 3-day 4-pill regimen, or they can take it every day when they're put themselves at risk. And then there's a thing called doxy-prep, where after an exposure, you not only are taking the HIV medicine, but you take 200 milligrams of doxycycline, and that cuts the rate of all these sexually transmitted infections significantly, not to zero, but whereas the PrEP is basically 100% effective. So in 1950, the older people who are watching, probably they may remember that every year when you had a annual physical exam, or you entered the hospital for any reason, you got tested for syphilis because it was the silent disease that causes problems later in life and whatever. So we were testing people for syphilis all the time. Well, then, the rates went down to almost zero, and now they're back up to where they were in 1950. In 2022, there were 207,000 cases. This resulted in 231 stillbirths and 51 infant deaths and a lot of problems. And the treatment is an intramuscular form of penicillin that is in short supply. They're basically running out of it because there's so many of these cases. Don't use that kind of penicillin, except for pretty much for cases like this. So there's a shortage of drug. And then there's a big variation between states. And the state with the highest by twice as high as the next one is South Dakota. Who would have thunk? New Mexico, Arkansas, Oklahoma, Mississippi, also big states with increases. So it's a problem that's still out there. And people who are having unprotected sex and are worried about, if they've had any infection, they need to be tested for syphilis as well as everything else.
Yes, it's just another thing to keep in mind. Protect yourself. Everyone, be safe in every sense of the word. And I would just like to thank you, Dr. Murphy, for your time and expertise breaking down this research, answering questions, and digging into the COVID statistics. Thank you.
Great. Thank you, Katie.
Thank you all for joining us this week for another episode of Ask Dr. Murphy. Please feel free to leave any questions you have down in the comments or at any of our social medias linked in the description. Have a great weekend, everyone.